All right, we'll get started. Thank you all for coming today. This is our first Lunch, Learn, Link seminar for the academic year 2019-2020. And as many of you know, we are broadcasting also over the internet, so I welcome our listeners from the Department of Health, University of Maryland, and Howard University especially, but there always may be others online. We are broadcasting this, so if there are colleagues of yours who were not aware of the seminar or who need to watch it later, we will be sending out the YouTube link for it. So this is 30 years of cancer prevention and control that we are celebrating. It was 2019 where the Maryland legislature passed a law to shape the spending of the cigarette fund restitution monies from the tobacco companies. And then it was 2020 where the programs actually really got up and running. So they included money to the local public health departments, the state health department, tobacco farmers, and then University of Maryland and Johns Hopkins as research entities and part of working to control cancer in the state of Maryland. I brought the most recent version of the Maryland Cancer Plan. This is on the web. Our speaker may actually talk about this also, but you can go out and look at it and download it if you want. But I think this is the 5th cancer plan since 1990 for the state of Maryland. So Maryland has really been progressive in this area. So to kind of summarize some of our progress and current issues, we've invited Dr. Lin Yai to come speak today. She is the director of the Center for Cancer Prevention and Control, which she has done for a number of years now. So I ask you to welcome her today.
All right, thank you so much, Norma. Good afternoon, everybody. Thank you for the invitation to speak in today's Lunch, Learn, Link. I still can't get that right. It brings me great joy to be on this side of the podium, having sat through some fascinating talks here myself as a student maybe 9-10 years ago. I am that old. To get to it, my name is Lin Yai. Like Norma mentioned, I'm the director of the Center for Cancer Prevention and Control at the Maryland Department of Health. And I'm here to tell you today in 45 minutes or less, challenge accepted, Norma, all about the Department of Health's past, current, and also future initiatives as it pertains to cancer prevention and control in Maryland. So before I go any further, I want to take this opportunity to give an overview of the Maryland Department of Health to those who may not be familiar with what we do. I understand it's very different in academia as compared to public health practice. So we work to promote and improve the health and safety of our residents through 4 main areas, namely disease prevention, access to care, quality management, and also community engagement. The department consists of 4 major administrations: the Public Health Services, which houses the administration that I work in, and takes care of the more traditional public health agency functions such as infectious disease control, food safety. We have the Behavioral Health Administration, Developmental Disabilities, and also the Medicaid Administration. There are also various boards and commissions that license and regulate healthcare professionals, such as physicians, nurses. Some of you may be aware of that. And we also conduct other activities, such as issuance of grants. We conduct research, and we make recommendations on the healthcare delivery system. The department oversees the local health departments in all 24 jurisdictions, and it's a fairly large organization. We have a staff of over 9,000 people and a budget of approximately $14 billion a year. So a lot of that is for Medicaid. So this is the mission and vision of the Prevention and Health Promotion Administration. I have to put this slide on. But in short, the mission of FIPA, as the administration is fondly known as, is to protect, promote, and also improve the health and well-being of Marylanders through the provision of public health leadership and community-based public health efforts. So what would I like to cover today? A couple of things. So I'll start with an overview of the state, as I realize that not everyone in the audience here is from Maryland or is familiar with the state outside of Baltimore City. We'll take a trip down memory lane and talk a little bit about the issues that were faced decades ago, as Norma had alluded to, and the steps that the state leadership and the Maryland Department of Health took to address those issues. We'll also talk about the current state of cancer in Maryland, looking through the lens of incidence and mortality rates, prevention, early detection, and also what we're doing right now in terms of programs and initiatives. And lastly, we'll have a little bit of discussion about where we go from here. So the state is comprised of 24 jurisdictions, or more commonly known as counties. The central part of Maryland is primarily urban, suburban, and population density is highest in the Baltimore-Washington area along the Interstate 94 corridor. So imagine a line going up northeast, connecting Montgomery County, Prince George's, Howard, Anne Arundel, Baltimore City, and then finally Baltimore County. The eastern and western part of the states are more rural and also very beautiful, so do take the opportunity to visit if you get a chance. And each region has its own particular terrain, culture, demographics, weather system, opportunities, and also challenges. And I've noticed that, like I mentioned, each jurisdiction has its own local health department, so they do a lot of the work on the ground on behalf of the state health department. The state has a population of about 6 million people and is considerably diverse racially, as evidenced by the numbers on the slide. In Maryland, non-Hispanic whites make up about 52% of population, non-Hispanic blacks about 30%, which is more than double the percentage nationally. Asians at about 6%, and Hispanics and Latinos at about 10%, which is below the national average of 18%. Even so, there can be large variation in these numbers. In some local jurisdictions, there could be, the percentage of non-Hispanic black populations could be as low as 1%. In some counties, as high as 60%. Also important to notice that even though our median household income is almost $79,000, or about $21,000 more than the national average, about 1 out of every 10 Marylanders live in poverty. One point that I like to make is that not all jurisdictions are created equally. The health outcomes really do vary geographically within the state. What you are seeing here is the Maryland Health Outcomes Map that was created by the University of Wisconsin, which portrays the rankings of each jurisdiction in the state. Now, health outcomes here are represented by 2 measures. One is how long people live, and secondly, how healthy people feel. The lighter the green, the higher the ranking. In other words, the better the health outcomes. We can see here that some of the counties in the western region, Eastern Shore, and also Baltimore City are in the lower quartiles of the ranking. So those are the states in the darker green. The counties in the darker green. So how are Maryland residents getting their health coverage? More than half of residents are covered by an employer in blue, which either as a policyholder or a dependent, followed by Medicaid at 18% and Medicare at 12%. About 6% are covered by non-group, which are policies purchased either directly from an insurance company, and other public, which include those covered under the Military or Veterans Administration. The uninsured rate in the state is about 6%, which comes to about 357,000 residents, and we are doing better than the national average of 8.5%. As part of the Affordable Care Act, Maryland expanded Medicaid to nearly all adults under age 65 with incomes at or below 138% of the federal poverty level, which is about $17,000 per year for a household of 1 person. As of December 2017, about 390,000 people were able to enroll in Medicaid because of the expansion, so fantastic. Health Choice is Maryland's statewide mandatory Medicaid and Children's Health Insurance Program managed care program, and there are currently 9 managed care organizations in the state. Health Choice covered more than 88% of the state's Medicaid and MCHIP program population in calendar year 2017, which translates to about 1.2 million people. So how do we get to where we are today? Let's take a look at the journey over the past 2.5 decades, almost 3 decades now. Some of you may remember that back in the early 90s, Maryland made the headlines for all the wrong reasons. It had the highest rate of cancer mortality compared to the rest of the nation, as reported by the Baltimore Sun. So it's never a fun thing to show up in the front page of the Sun. These statistics later served as the catalyst for creation of programs, activities, and partnerships that have contributed to the decline in cancer incidence and mortality rates over the next few decades. One of the state's initial responses to the unwelcome ranking was to form the Maryland State Council on Cancer Control in 1991. The council was established via executive order from the governor of the state of Maryland, and the council is charged with educating and advising government officials, public and private organizations, and the general public on existing and possible policies, programs, and innovations to reduce and control cancer incidence and mortality among Marylanders. The members are appointed by the governor and represent a wide array of cancer stakeholders in Maryland, such as medical institutions, the general public, business community, members of the Maryland General Assembly, and health and science disciplines concerned with cancer control. Also in 1991, Maryland published its first state cancer control plan, which was made possible through the National Cancer Institute's Database Intervention Research Program grant. Covers of those plans weren't as creative as they are today. So the plan contained chapters that focus on population-based screening for breast and cervical cancer and reducing tobacco use. During this time period, Maryland also received CDC funds as one of the first 12 states to do so, to roll out a breast and cervical cancer screening program. Maryland later trained all the other states that came on board across the nation to expand on the program. The breast and cervical cancer diagnosis and treatment program was also established in 1992 to help women needing a diagnosis or those who were diagnosed with cervical or breast cancer with the treatment costs. Slowly but surely, with the efforts of all the stakeholders in the state, we started seeing improvements in our cancer mortality rates, as shown in the newspaper clips there. So on the back of the state's initial efforts and its related improvements, in 1999, Governor Glendening presented a 10-year vision focused on making substantial advances in education, health, and tobacco crop conversion within the state using funds from the tobacco settlement. The Task Force to Conquer Cancer in Maryland was established and charged with providing recommendations to the governor on how to best spend the funds earmarked towards combating cancer in Maryland. The report of the governor's Task Force to Conquer Cancer in Maryland was released to the public on December of 1999. So at the turn of the century, the Maryland General Assembly established the Maryland Cigarette Restitution Fund, or commonly known as CRF, with funds derived from the 1998 Master Tobacco Settlement Agreement with the tobacco industry. So the goal of the CRF program is to implement strategies to reduce the burden of tobacco-related disease in Maryland, with a specific emphasis on tobacco-related disease, tobacco use prevention cessation, and also cancer prevention, early detection, and treatment. The creation of the CR program was one of the turning points, I would say, in Maryland's efforts to reduce tobacco use and cancer morbidity and mortality, because it allowed for the creation of focused tobacco use prevention and cessation programs, cancer prevention, education, and screening programs, cancer research programs, and also a strong statewide network of cancer and tobacco local community coalitions that are still existing today. So more progress was being made. In 2002, the Women's Breast and Cervical Cancer Health Program was created to provide Medicaid coverage to uninsured women who were screened through the breast and cervical cancer program and were diagnosed to be in need of treatment for breast and cervical cancer. Do note that this program ended in December 2013 with the implementation of the Affordable Care Act. And in 2004, the 2004-2008 Maryland Comprehensive Cancer Control Plan was released. In the same year, House Bill 1000 was passed, which established the Maryland Cancer Fund within the Maryland Department of Health, and I'll talk a little bit more about that program later. And the decade also saw the passage of the Clean Indoor Act and legislation requiring parental consent for the use of indoor tanning beds for individuals under the age of 18. The colorectal cancer program was also established with funding provided by the CDC. And in 2011, the 2011-2015 Maryland Comprehensive Cancer Control Plan was released. And in an example of a success resulting from Maryland's efforts, the state was mentioned in the CDC's report on colorectal cancer screening, which reported that CRC incidence rates decreased significantly in 35 states from 2003 to 2007, with Maryland reporting the largest percentage decrease in CRC incidence at 6.5% per year. And in 2013, there was more mention of the progress that we were making as a state, as you can see in the Baltimore Sun article. So slowly but surely, we were making progress. More recently, the 2016-2020 Maryland Comprehensive Cancer Control Plan that Norma was showing off just now was released. The department also rolled out several new initiatives, namely patient navigation, lung cancer screening, and collaborations with health systems and health departments focusing on improving cancer screening rates. We are in the midst of developing the 2021-2025 plan, so if any of you are interested in providing feedback, you're more than welcome to do so. Please let me know. And as a result of hard work put in by all the cancer stakeholders in Maryland, including work being done here at Johns Hopkins, mortality rates have improved, as in the historical trends graph here, so much so that there is no longer a gap between Maryland's rates in red compared to the US rates in blue. Between 2007 and 2016, the annual overall cancer incidence rates declined by 0.4% per year, while the annual cancer mortality rates declined by 1.8% per year. We're also being helped by the changes in the national healthcare landscape. Findings from the recently concluded 2019 American Society of Clinical Oncology annual meeting showed that in states that adopted Medicaid expansion, prior racial disparities in access to timely cancer treatment were no longer observed. So that's fantastic to hear. And two physicians from Hopkins, Dr. Smith and Dr. Nichols-Fader, found that under the Affordable Care Act, women with ovarian cancer were more likely to be diagnosed at earlier stages and also to be treated within 30 days than in prior years. So it's fantastic. So how are we doing today? So in 2016, which is the year with the latest available data, there were about 31,000 new cases of cancer and almost 11,000 deaths arising from cancer. It is still the second leading cause of death in Maryland, just a few percentage points behind heart disease. Our incidence rate of 443.6 per 100,000 people is higher than that of the US rate. And our mortality rate of 156.5 per 100,000 is just a tad higher than that of US rates. As mentioned earlier, we have made strides in reducing our incidence and mortality rates, but we are still seeing disparities based on race or ethnicity, region of residence, so where you live does matter, and socioeconomic status. When we look at the last 5 years of most recently available data between 2012 and 2016, the incidence rate for all cancer sites increased slightly at a rate of 0.5% per year, so work still remains. The good news is during the same time frame, cancer mortality rates are still decreasing at a rate of 1.6% per year. So how do we compare nationally? Not too bad. We're 35th in the country for incidence rates. And here in this map, the states with the best incidence rates are in dark blue, and the worst rates are in red, and we are a light blue state. For mortality rates, we are ranked 32 in the country. Same thing here. States with the best rates are in dark blue, and the worst rates are in red, and we are still a light blue state. So let's look a little closer at cancer incidence in the state. So in 2016, female breast cancer was the top cancer diagnosed in Maryland, followed closely by prostate. And I apologize if that didn't come up too clearly. Lung, colorectal, uterus, melanoma, urinary bladder, non-Hodgkin lymphoma, kidney and renal pelvis, and thyroid cancers all round up the list. And this is how the racial breakdown incidence rates look like, with the incidence rate highest in whites, followed by African Americans. Whites are in orange, African Americans in green, yellow is others, and Hispanic of any race is in gray. So this has been a trend for years. And this map of the state shows the existing of geographic disparities for cancer incidence in Maryland. The counties in blue are the counties with incidence rates that are 10 to 25% above the US rate. The counties in darker green have rates that are between 10% below and 10% above the US rate. And the light green counties have a rate of that is 10 to 25% below the US rate. So there's only one county that currently is more than 25% below the US rate, and that's Montgomery County. So one would note that most counties in Maryland have cancer incidence rates that are comparable to the national rate. What about cancer mortality? So the top 10 cancers based on age-adjusted mortality rates in Maryland were lung and bronchus, female breast, prostate, colorectal, pancreas, ovary, liver, and intrahepatic bile duct, uterus, leukemia, and also non-Hodgkin lymphoma. And this chart shows that African Americans have higher mortality rates than whites, even though, if you can recall, they have lower incidence rates. So again, whites in orange, African Americans are green, others yellow, and Hispanic of any race are gray. The good news is that we are seeing the cancer mortality gap narrowing between the African Americans with their line in red compared to the whites, which are represented by the green line. As we highlighted earlier in the geographic diversity of health outcomes and cancer incidence in Maryland, cancer mortality rates do vary throughout the state too. Many local jurisdictions in Maryland have cancer mortality rates comparable to the rest of the US. Garrett, Howard, Talbot, and Montgomery counties have led the way by having cancer mortality rates at least 10% lower than the national rate. Baltimore City, unfortunately, has the highest cancer mortality rate in Maryland, with a rate that is more than 25% above the national rate for cancer deaths. So a lot of work to be done there. Next, I'd like to spend a few minutes to talk about cancer screening and risk factors. So based on Maryland BRFA's data, 81.2% of women ages 50 and above have had a mammogram in the last 2 years. The rates have been steadily declining, though, which is not good. In 2012, it was 83.8%. For cervical cancer screening, 81.3% of women ages 21 to 65 have had a Pap test in the past 3 years. The rates for this screening has also been steadily declining. In 2012, it was 88.2%. Colorectal cancer screening rates at 72.5% have been somewhat steady, but still a ways to go to reach the 80% target of the National Colorectal Cancer Roundtable. And the new kid on the block, lung cancer screening, has a rate of about 13.9%, which is not too bad. A recent study looking at 10 states showed that only 14.4% of eligible individuals had a CT to screen for lung cancer. So we're about there. When we look at the Medicaid population, particularly those enrolled in Health Choice, screening rates are lower across the board. Breast cancer screening is 69.7%, cervical cancer screening is 62.4%, and more worrying is colorectal cancer screening is only 39%. So one thing this slide shows us is that access to health insurance and care does not always equate to utilization. This can be affected by factors such as low health literacy, lack of familiarity with accessing care through Medicaid, or just limited experience in managing through a healthcare system. I've added this slide to show that state-level screening estimates can be masked by local variations. This is a map showing breast cancer screening rates by jurisdiction. As you can see, there are jurisdictions where the rates are well below the state average. In those counties are in light yellow, and those counties are predominantly in the Eastern Shore. And ditto for this slide, which shows colorectal cancer screening rates by jurisdiction, so a lot of variation there too. Both the breast and colorectal cancer screening maps highlight the need for planning and targeting resource allocation to particular sections of the state that needs the most. So aside from screening, the other things that we can work on include decreasing risk factors for cancer. In Maryland, about 13.6% of adults are binge drinkers, meaning that they have 5 or more drinks per occasion for men and 4 for women. About 4.5% consider themselves to be heavy drinkers, meaning more than 14 drinks per week for men and more than 7 drinks per week for women. And as everyone is aware, obesity rates are skyrocketing. Almost a third of Marylanders are obese and another third are overweight. Only half reported that they participated in 150 minutes or more of aerobic physical activity per week. So a lot of work there. And HPV vaccination rates are less than 50%, although our state's rates are considerably better than most others in the country. One of the biggest risk factors for cancer is tobacco, so I need to talk about that. Since 1995, adult cigarette smoking has been on the decline. It is good to note that Maryland has consistently had a lower percentage of adult smoking than the United States as a whole, but regardless, tobacco usage rates are 18.2% in 2018, which is up from 17.9% in 2016. Cigarettes are still the most popular product, leading the way at 12.5%. However, we have to be on alert for the rapid rise of cigars and also electronic smoking devices such as Juul. There are also jurisdictions in the state with particularly high rates of tobacco or electronic smoking device use, shown here in red. It's important to note that the jurisdictions with the lowest tobacco usage rates, the ones in green and yellow, tend to be the larger, more populous jurisdictions. So this can sometimes disguise the extent to which Maryland is still facing significant public health issues arising from tobacco use, particularly in rural areas and in Baltimore City. So we spoke about some of the history behind cancer control in the department, and what about what we have today in terms of programs and initiatives? So at the Maryland Department of Health, the Center for Cancer Prevention Control is tasked with reducing the burden of cancer in Maryland. We do so by providing guidance, support, and funding for effective cancer programs. We foster collaboration among partners, and we evaluate outcomes through data collection and analysis. We are a fairly large office. We have 45 employees and 8 programs working on internal and external collaborations. The first program I'd like to talk about is the Cigarette Restitution Fund Cancer Prevention, Education, Screening, and Treatment Program. This program provides funding to 22 local health departments and 2 health systems to implement community-based programs to prevent and or detect 7 targeted cancers throughout the state via the activities listed below, such as screening, diagnosis, outreach, community health coalitions, and partnerships. And the 7 targeted cancers are lung, breast, cervical, colorectal, skin, melanoma in particular, oral, and prostate. The Cigarette Restitution Fund also provides funding to Johns Hopkins University and the University of Maryland, Baltimore to conduct translational cancer research with the hope that the research activities will lead to a cure for targeted cancers and that they can be translated into treatment protocols in the state. Dr. Norma Kanarak is the executive director for the Cigarette Restitution Fund research grant here at Hopkins. So she will be your go-to person if you have a brilliant research idea that you need money for. So there she is. The next program I want to talk about is the Breast and Cervical Cancer Program. The program is a grantee of the CDC's National Breast and Cervical Cancer Early Detection Program and also receives state funds. The program awards grants to 13 local health departments and 2 health systems to implement activities specifically for breast and cervical cancer, such as screening, diagnosis services, public education, health coalitions, and also partnerships. Note that this program cannot pay for treatment, as that is outside the mandate of the CDC program. And next is the Colorectal Cancer Control Program. So what is this program? From 2005 to 2009, a CDC-funded demonstration program was held in 5 cities in the country, including Baltimore City. The grant provided colorectal cancer screening tests to low-income, uninsured, or underinsured men and women. And then later on in 2010, the CDC moved its focus to increasing screening rates on a population level. This was done via implementing evidence-based interventions and other supporting strategies in partnerships with health systems. We currently have 14 partners with work being done in 37 clinics across the state. And priority evidence-based interventions include provider assessment and feedback, provider reminders, client reminders, and also ways to reduce structural barriers to getting screened. The next program is the Breast and Cervical Cancer Diagnosis and Treatment Program. It's a fairly unique program to the state. This program reimburses contracted providers for breast and cervical cancer diagnosis and treatment services for low-income, uninsured or underinsured Maryland residents. And there are over 1,600 participating providers statewide to serve the residents of the program. The Maryland Comprehensive Cancer Control Program is supported by a cooperative agreement from the CDC and works with individuals and organizations to develop and implement the Maryland Comprehensive Cancer Control Plan. The program also facilitates collaboration between existing and new partners across the state. And it also provides administrative support to the Maryland State Council on Cancer Control that I described earlier. Members from Hopkins at the council actually include Dr. Bill Nelson and Dr. Elizabeth Platts, who's here today. Dr. Platts also chairs our Maryland Cancer Registry Advisory Committee. The next one is the Patient Navigation Network. It brings together individuals that work in navigating patients through cancer care. There are currently about 250 members in the state. And the Maryland Cancer Collaborative is a statewide coalition of volunteers charged with implementing the cancer plan. And members can choose priorities from the cancer plan, form work groups, and also develop and implement the action plans. So there are currently 5 work groups in the Maryland Cancer Collaborative right now. The tobacco work group provides healthcare providers with additional resources to refer patients to the Maryland Tobacco Quit line and also increase referrals to via electronic health records. The HPV work group is tasked with increasing awareness of the HPV vaccination and also awareness of HPV infection as a cancer risk factor, and also implement system changes to increase vaccination rates. The communications work group is focused on increasing awareness to underappreciated and lesser known cancer risk factors such as radon and hepatitis. The targeted outreach group seeks to increase community engagement with minority and other underserved populations. And lastly, the cancer survivorship palliative care and hospice group works to educate cancer patients and their caregivers about survivorship care plans and also palliative and hospice care options. The Maryland Cancer Fund awards grants for cancer diagnosis and treatment for program-eligible individuals and also to organizations to conduct primary and secondary prevention activities. I'm sure you're wondering why the picture is there. One of the prevention grants I'm particularly fond of was helping the Worcester County Health Department implement their no smoking on the beach. If you want to see on the right side of the screen, that was the ordinance that they implemented on the Ocean City Boardwalk in 2015. So I think they've recently changed it to include vaping too, so that's amazing. I'd like to point out that monies for the fund is collected solely by contributions from the public via tax check-off or direct donations, so we're always appealing for donations. We also have the Surveillance and Evaluation Unit, which collects, analyzes, and monitors data related to targeted cancers. The unit helps us measure and evaluate our Cigarette Restitution Fund, Cancer Prevention, Education, Screening, and Treatment grantees by using two databases. The first is a client database, which collects demographic and clinical information, and the second one is an education database, which collects education outreach information. And this is a program that may be familiar to cancer researchers in the audience. The Maryland Cancer Registry is supported by a cooperative agreement with the CDC and also with state funds. It collects new cases of cancer and benign central nervous system tumors among Maryland residents, and reporting to the registry is mandatory. So the registry gets information from hospitals, radiation therapy centers, freestanding diagnostic laboratories, freestanding ambulatory care facilities, and physicians. And what the registry does is it prepares and disseminates data and reports on the incidence and stage of cancer at diagnosis. And the reports are typically used for various purposes such as resource planning and also cancer cluster investigations. So we also have multiple partnerships and collaborations, and I'll just run through them fairly quickly. We work with our sister offices in the Cancer and Chronic Disease Bureau, such as tobacco, for example, ensuring that our program clients are referred to the quit line if applicable, working with oral health on HPV awareness initiatives. The HPV Vaccination Task Force has hosted symposiums with clinicians and health professionals to increase the rate of HPV vaccination in provider offices. Via the Maryland Cancer Collaborative, a partnership with the Maryland chapter of the American Academy of Pediatrics and Pediatric Practices led to HPV vaccination projects. And we also have a catch-up project with UMBC and UMB University Health Systems targeting young adults. The Maryland Colorectal Cancer Task Force is a volunteer-led effort designed to reduce colorectal cancer incidence and mortality in the state. Partners include the American Cancer Society, Medicaid, managed care organizations, primary care associations, clinics, and hospitals. And we also have worked with local health departments, healthcare providers, employers, making sure that policies are promoting cancer screening for their employees, and also with the National Colorectal Cancer and Lung Cancer Roundtables. Some recent Department of Health activities to promote health equity as it relates to cancer control include Cancer Thriving and Surviving workshops, patient navigation training for rural and Appalachian communities, and presentations by experts on particular underserved populations. Also of note, there have been some recent positive legislative changes. Beginning October 1st, 2019, the new minimum sales age for all tobacco products in Maryland is now 21 and no longer 18. This includes sales of all electronic smoking devices such as e-cigarettes and Juuls. And shown on your right is a law that has been years in the making. Effective October 1st, 2019, it's not unlawful for tanning facilities to allow minors under the age of 18 years to use a tanning device, which includes sun lamps, tanning booths, and also tanning beds. So big wins for cancer prevention in the state. So I'm also pleased to share that through the department's programs, with the important help of our stakeholders, such as Hopkins, we've reached thousands of our most vulnerable populations, the uninsured, underinsured, low-income populations. So you can see these are the number of people that we have served throughout the decades. So pretty impressive numbers, but definitely more to serve. So where do we go from here? So a couple of things. First is a lot of our programs target uninsured populations. So what we have seen recently is a decrease in the number of clients that we serve, especially after the implementation of the Affordable Care Act and Medicaid expansion, which is not a bad thing. But we do note that there are still pockets of uninsured individuals that are out there that can benefit from our services. They're just a little harder to find right now. We have to expand our reach to these populations. And one of the ways that we're trying to do so is to increase our community clinical linkages, reaching the populations where they are via help from organizations rooted in the community, such as faith-based organizations, nonprofits, and so on and so forth. There has also been more awareness about the needs of populations such as the LGBTQ community and also individuals with disabilities. About 21.6% of adults in Maryland report that they have some type of disability, so it's a fairly large population there. We also know that these communities suffer from disproportionate burden of cancer. They also face disparities in receipt of cancer screening services. They have distinctive risk factors such as higher alcohol or tobacco use. And additional barriers to seeking care, all things which we should continue addressing. And next, if we really want to move the needle on increasing the state screening rates, the focus will need to be on increasing population level screening through working with our health systems, meeting the providers and patients where they are. We also have our work cut out for us with persistent and emerging risk factors such as tobacco, obesity, alcohol use, and hepatitis C. So much so that the department even came up with a strategic plan to address hepatitis C back in January of this year. We plan to address these risk factors via partnerships because we really can't do it all by ourselves. For example, working with our chronic disease counterparts to address obesity rates in the state and ensuring the quick translation of research into public health practice. And this is where academics and researchers like yourselves come in. One of the other things that we will do is to continue to track cancer trends in the population in an effort to try and get ahead of these cancers. And what I'm going to show you is this chart here, which shows a 5-year incidence rate change and lets us know which cancer rates are falling and which ones are rising. The bars in red are the ones that we are tracking because those are the ones with rising incidence rates. We see that melanoma is showing the highest increase percentage-wise. We know that between 2012 to 2016, melanoma incidence rates increased at a rate of 4.1% per year among males and 5% per year among females. So another cancer of interest recently is cancer of the uterus, which is rising and is currently above the US rate. Researchers believe that it's tied to rising obesity rates, as with some of these other cancers. So that's definitely something that we're tracking. So I know I'm all that's standing between you and the pizza outside. So let me end my presentation here, and I'd be more than happy to take any questions. Thank you.
Kenlin, thanks so much. We'll take some questions from the audience, but I just want to remind the in-house audience that if you want pizza, you should have a ticket, and if you don't have a ticket, get one as you go out that door. And we have pizza in the gallery, so we'd love to have you. Much appreciate your words of wisdom and about the progress of cancer in Maryland, Kenlin. Do we have questions from the audience?
Hi there. So we have some students in the room, and so I'd like to ask you, how can students get involved in true cancer control in the state? So not just their research, but truly making a difference in participating in cancer control activities.
Right, so that's a great question, Elizabeth. The first one is joining the Maryland Department of Health. We're always looking for good people to work at the department. I know things can be more inviting in the private sector, but really public health agencies rely on public health graduates to do the work. Some of the other things that students can get involved with is internships, for example. The FACE internship program is a wonderful program. We've had a lot of interns rotate through us. We've loved the work that they've done. Some of them come up with brilliant ideas on things that we've never thought about because of the work that they've done here at the school or just with their prior experiences. So that's one of the ways to get involved. Other things are, if you don't want to do an internship, just come and learn and see what we do and maybe learn a thing or two on how public health agencies work. Some of the things is getting involved in the community. We have a lot of disparities. So when we talk about risk factors, certain populations are typically more affected than others. So really, putting in that community work, partnering with a nonprofit or a community-based organization to make a change. So those are some of the things I can think about.
Kenlin, do you happen to know who the phase contact is here at Johns Hopkins?
Yeah, is it Polana?
Polana Mew?
Yeah, I've been getting some
Okay.
emails from her.
Okay.
Yeah. So yeah, we're always looking for FACE interns. So if you're ever interested, let us know.
So you can do your practicum at the State Health Department, but phase actually adds a little more structure to it.
Right, yeah, we've had students do evaluation type work, whatever suits their fancy, and we'd have students move on based on the work that they've done with us to bigger and better things. Some have ended up at the NCI doing research and things like that. So really a good stepping stone to figuring out if cancer prevention and control is what you want to do.
Other questions?
Great presentation.
Thank you.
Tom Burke and have a nice history of working with Norma and others. Perhaps during a time when the environment was more of a focus on some of the prevention efforts. And I wanted to ask you about that in terms of the work groups and things like that. I think we're redefining and understanding the environment a lot better, particularly the occupational environment and the way that we are exposed. Some of those cancers that are of concern now have been linked to certain practices in the environment and things in our food. And I'm just wondering, I'd like to get your take on kind of focus and interest in weaving environment into cancer prevention efforts.
Right, so great question. Definitely one of the things that we are focusing on in our upcoming cancer control plan is really, looking at those environmental risk factors. Occupational-wise, we do work with the Environmental Health Bureau, and they've been at the forefront of a lot of the work we're doing at the Department of Health, but really looking at things, lesser-known risk factors, for example, for lung cancer, radon. It's everywhere, it's around us, but not a lot of people are aware that it is a risk factor for lung cancer. Whenever you think lung cancer, you associate it with cigarette smoking and tobacco use, but there's more than that. So really creating the awareness with the population. The second of all is making it a priority. Again, there's so many things, so many risk factors that we look at when we think about cancer that we tend to overlook occupational and environmental health. We usually think of somebody else will deal with that. For example, firefighters, for example, are exposed to a lot of carcinogenic risk exposures. So I think one of the things that we need to do moving forward is working with those populations, working with those organizations and those bodies to say your populations are at particularly high risk for cancers. What can we do to help decrease that risk for them?
There is a speaker that's scheduled through Lunch Learn Link the third Thursday in January. That's Dr. Polavaram will talk about radon, and as part of our cooperation with the State Health Department.
Perfect.
On risk factors. Yeah. And Kenlyn, would you want to say something about the environmental public health tracking at the state? I know it's not in your unit, but.
Oh yeah, absolutely, yeah. And I didn't bring those slides, but we do have the tracking portal, and if you Google it, you can find it. It basically is a pretty cool tool that anybody can use to look at cancer incidence and mortality. If you like maps, this is going to be the tool for you. I don't think we have all the cancers on that yet because it is a pretty tedious process to put all the rates in. But we're working on getting it as accessible as possible to anybody who might want to use it. We've generally been using it for internal purposes, but we know that there are a lot of researchers and also general public who could benefit from that tracking tool.
And they've incorporated a lot of demographics at even the census tract level.
Absolutely, yep,
So.
that's right. And that's where a lot of the time factor comes in because there's a lot of work in putting in every census tract.
Yeah.
Yep.
We keep cheering them on. And I don't know, some of you might know Dr. Cliff Mitchell. He's the leader of that effort at the State Health Department.
Yep,
too.
that's right. We also work very closely with Cliff and the Environmental Health Bureau when we investigate potential cancer clusters in the state. And that's so using data from the cancer registry and the tracking tool is really important for us.
Other questions? I'll ask one about colorectal cancer and the leveling of the screening prevalence in the state. What do you think is the next thing that should be done to help jolt that use of colorectal exams?
Right.
We have the FIT test now.
Yeah, so excellent question. So that's exactly where we're heading is understanding that the best test is any test that's being done. So in the past, we've had a focus on promoting colonoscopies because, you can go in there, you can remove precancerous lesions, that's great. But a lot of people don't want to do colonoscopies. It's a lot of time and people just don't like the procedure. So we've had a hard time trying to convince most people to get them. Now we have other tests available. FIT is one of them. So what we're doing right now is we're promoting FIT. It's easy to do, it's cheap, anybody can do it. So that's what we're encouraging all our screening programs to do right now is, we shouldn't just push colonoscopies. let's just make sure everybody gets screened, using whichever test that they feel most comfortable with. Now we can present the risks and benefits for each test. Again, if you have a positive fit, that usually means a colonoscopy. But if a colonoscopy is a barrier to getting someone screened, we would rather someone have a fit rather than nothing at all.
Mm-hmm.
So that's something that we're trying to push right now. But great point, Norma.
Well, actually, the same vein for cervical cancer screening.
All right.
So cervical cancer screening rates have gone down in our state. Is there any evidence that those who are the ones who should be screened are not being screened because they've now had HPV vaccination and are thinking that they shouldn't be screened or don't need to be screened any longer? Is there any evidence for that yet?
Yeah, I don't know if there's any literature out on that yet, but I wouldn't be surprised if that's the thinking, because sometimes people can be lulled into thinking, because I have the HPV vaccination, I don't need to get screened anymore. So I think there needs to be a lot of education that goes into that to make sure that people still get screened, because it doesn't prevent all forms of the virus. So again, it's education, but that's a great point. We're trying to figure out why the screening rates have dropped for cervical cancer screening. Is it because people think it's not a problem anymore, or if there's something else, or it's just access to care? So that's something that we're still trying to parse out. Thanks.
So you spoke about disparities, geographic disparities, and because we're situated right here in Baltimore City, what do you think the priorities are here for the state? I know you won't speak for this city.
I'm not quite sure where to start with the city. I think definitely getting the city health department involved. They know the people the best. They know their neighborhoods. They know their needs and the communities. We can only do so much at the state health department. We do provide funding for them. For example, in Baltimore City, we provide funding to MedStar to provide colorectal cancer screening and also breast and cervical cancer screening. But I think we can work a lot more with the city health department and figuring out how we can tackle this, maybe even one neighborhood at a time. I think the problem is it's multifactorial. There are a lot of things going on here. Cancer is only one of several concerns health-wise for the population. We're dealing with diabetes, hypertension, heart disease. Those are a lot of things that are killing the population too. So how do we get together with the city health department and make sure that we can work and we can target these risk factors, making sure that people get screening when they can, and if they can't afford to, how do we get them connected to care and things like that.
Just another hard question. So I've been following cancer incidence, and I hadn't noticed that between the last 2 years of reporting, between 2015 and 16, there actually had been a drop in incidence. Have you explored that to know where the lack of cases is coming from? Is it lung cancer,
Right.
or is it?
So no, yeah, we haven't, because we just got the data, so we're still looking at that. But we'll be sure to keep you updated, because we're asking the same questions too.
Yeah, that's a new development, I think. Mm-hmm. Very good. Any other questions here from the audience? Well, we thank everybody for coming.